Next slide. So this is a novel generation, fourth generation CCB. Next slide. And it is approved since 1995, and yet you may not have heard of it for various reasons, which I will explain. But since then, it has been around from Japan, which is where most of the research takes place, and you get highly selective L and N type blockage with large reduction in pressure. This is what causes reduction in proteinuria because it's there in both sides of the glomerular afferent and efferent arterioles. It causes less pedal edema because it does there also. The arteriole in the skin and the venule in the skin is equally dilated, minimal reflex or no tachycardia. And the guidelines of various organizations will have approved of it. Next slide. So where did it start from? Next slide. It started from Japan. And then Japan brought what even today North America doesn't have. So in America, you still have nifedipine, diltiazem, amlodipine, verapamil. But Japan was good enough to get this research going. And the Professor Cario, I take my hat off to him. I think most of these slides have also come from Professor Cario's textbooks on these calcium channel blockers. They're worth reading. And that's how it's been negotiated. Next slide. You see here a pathway of these various trials. I can't go into depth, but you have starting from the Carter trial, then the Kyoto study, then the Achieve trial, and etc. And it comes right down to the latest, what you get in India, the two trials, RSSDI, this is the Diabetic Society of India Research and Society, and the Association of Physicians of India have approved these drugs. Next slide, please. And today, even it is doing very, very useful to the patients of India. How it works is that it protects the special podocytes by restoring podocin and nephrin expression on them. These are, of course, in-depth explanations, and it has antioxidative properties, protects endothelium from the reactive oxygen species mediated damage. You see here very good picture of those lovely podocytes from on electron microscopy. Next. And it shows here, this is a rat experiment, that when you give only the L-type nifedipine to the rat, the afferent and efferent, they gap widens. It becomes, as you see, large. Whereas when you give the L and N-type cilnidipine, the gap between afferent pressure and efferent pressure by microcirculation measurements, it becomes the less. So both pressures increase equally or decrease equally. So this is the delta. So the diameter increases. So you see that the equality of dilatation of the two vessels. Next slide. And you see that in this you have the effect on proteinuria, that when this is a Carter trial, is a head-to-head comparison and shows you proteinuria much reduced in the patient with cilnidipine, which is the black bars, whereas in amlodipine, there is either no reduction or very little reduction. Then you see that from the black bar is cilnidipine, the gray bar is the amlodipine. Next slide. And this shows you the Indian study that has been done and shows in this group of patients, cilnidipine given in 10 and 20 milligram doses, systolic BP reduction of 17, diastolic of 6.6 millimeter, and heart rate reduction of 6 to 9 beats per minute, and proteinuria reduction of 52 milligrams. So no significant deterioration of eGFR took place. This is an Indian study, well validated. Next slide. And this again shows you, I won't go into depth, but changes in heart rate, improvement in left ventricular function, reduction in arterial stiffness, and reduction in central aortic pressure stiffness. One of the reasons why the central aortic pressure is important is actually the damage to the organs, be it the heart muscle or the renal artery, is the pressure transmitted from the aorta, not from the brachial artery. You in the office are measuring brachial pressure, but what is it really lowering aortic pressure? You can see the proof that it is lowering the pressure. Next slide. And you see the same in this Carter study. I think it's come again, this one. You can skip it, please. That the amlodipine did not reduce proteinuria. Next. Next, please. Let's speed up, please. Yeah, same, that sympatholytic. This is on heart rate. Heart rate is sympatholytic, and you see that the higher heart rate, the more is the reduction with these drugs, all calcium channel blockers, and the significant reduction in the pulse rate after administering the drug in the ACHIEVE trial. Next slide. You see the same thing, another trial that is pressure, proteinuria. Sorry, this is heart rate, and amlodipine increases the heart rate. This is a terrible problem. Amlodipine increases the heart rate. People feel palpitations, and it can increase and precipitate atrial fibrillation also. Next slide. Clinidipine decreased the heart rate here in another study. This has been shown. Next slide. And this is the Kyoto study, which shows that serum creatinine did not change much with cilnidipine, but with L-channel, it increased the creatinine. Next slide. And the same with blood pressure, the reductions are good. This proves it. Next slide. So we'll run through these quickly, and I know we're running short of time. Next slide, please. There's particularly diabetics. And this study, again from a Japanese trial, shows us that microalbuminuria, as I said, all these trials have been done together with CCB and ARB. The significance of CCB is that's a good addition to ARB and prevents the side effects of dosing with ARB doses. So same with ACE inhibitor. So here, because of the various limitations of the dose, the change in protein creatinine ratio was only 9%. And then with addition of, with ARB, it was 9%. And with addition of cilnidipine, it was 44%. A significant change. Next slide. And these are the validations. This is from the European Society of Cardiology textbook. Next slide. This is from the Association of Physicians of India. This is from the RSSDI, the Indian Study of Diabetes. Next slide. And this is my last slide. It tells you, having said that, nothing is perfect. We still have a large number of patients who need more effort, more therapy, and various other non-therapeutic interventions, which will then reduce the effect on CKD progression. We want our patient who has a 10-year-old daughter and a 15-year-old boy itching to go to America and become a doctor. We want their pressures to come down so that they don't go on to CKD at 5 years later, but go on to 25 years more and have, grandchildren and see their grandson get married. This is the type of life. And the new drugs coming on the block, therefore, for reduction are of course, the ACE inhibitors, then the SGLT2, non-steroidal MRAs, that is the phenurone, and the endothelial receptor antagonists with these various trials which you are seeing. So in this short period, thank you for having been attentive and listened to us. I hope this has been if there have been any queries, you may feel free to call. I think they will be relayed to me, and I'm trying my best.